Hi everybody, welcome to our second edition of our Facebook and Instagram Q&A, and we're going to talk a little bit about what we can do in the interim while we're waiting for things to actually get a little better out there. We just basically got a new warning in Florida today that for the next 30 days we're pretty much on stay-at-home orders. So, we'll be kind of hanging in there, hanging tight, and definitely we're going to be needing a lot of support for sure for all of our patients and all of our friends. So, I know that we've been talking a little bit about some strategies that can really be helpful as far as stress relief techniques and those sort of things. But we're also going to talk a little bit about what you can do at home today to to actually help with maximizing your fertility and also helping with things that you can do naturally as far as regulating your cycle. And looking at things that we can do to help with charting our temperatures and things like that. We've actually been working with some of our patients distally with telemedicine, as many practitioners have been doing as well. And being an acupuncturist, it was definitely an adjustment to do that. But I think that it's definitely something that has been helpful. It's not a substitution for our treatment, but it is very helpful to see, things that we can actually do in the meantime without needles, without hands-on treatment. So we're going to talk a little bit about those strategies today, and I want you guys to feel free to ask questions as well. I'm going to have Dr. Ellen Wood on right now, so I'm going to go ahead and bring her on from IVFMD, and similar to last week, we're going to actually take your questions, and we're going to be discussing some really cool tips we've used throughout the years with many patients, and get some of your questions answered as new things have come out every single day now about how coronavirus can affect male fertility, or it doesn't, and what types of treatments honestly are being utilized out there for patients who are pregnant. Is it okay to be pregnant in this environment right now? So definitely I'm going to go ahead and bring Dr. Wood on. We're going to talk a little bit about some strategies to really help. So let's go ahead and I want you guys to jump in the conversation. Please don't be shy and ask questions about what we can do. Hey, there's Dr. Wood. How are you?
Hey, hi, nice to
Hey.
So thanks for letting me join.
Thanks for joining us, and hopefully we're going to actually be answering a lot of questions that have been popping up there about what to do at home now, some strategies that can actually help as far as maximizing your fertility, and also looking at things that we talked about, such as temperature charting, which I know doesn't get talked about a whole lot nowadays, but we actually do find it pretty helpful. So thanks for coming on, and thanks for joining us.
Hi, welcome. So we can just talk about, since there are many natural ways that you can monitor your fertility. If you're kind of stuck at home, you want to have a baby. I mean, they are predicting a huge baby boom for next December, just because everyone hasn't been so close to each other and kind of together. But one thing is temperature charting. So if you're not quite sure exactly where you are in your fertility cycle, I mean, there's monitors out there that a lot of people buy, and there's urine kits that they can use. But as a general rule, okay, what a basal body temperature is your temperature prior to ovulation is going to be lower than your temperature after ovulation. Okay, this has nothing to do with the temperatures we're taking as far as a virus is concerned or an illness. Okay, but in general, if you take your temperature before you get out of bed and you do nothing, okay, before you just have to put the thermometer in your mouth, prior to ovulation, your temperature should be essentially 98 degrees or below. This is an oral temperature. If you take your temperature after ovulation, it should be above 98.6, usually 99 or above, because the hormone that's produced after ovulation, which is called progesterone, has a thermogenic effect. So if you take your temperature and your temperature is up above 98.6, 99 for 12 to 14 days after you feel you've ovulated, you're most likely pregnant. And that's the time to go out and get a pregnancy test, because again, that's what pregnancy does. It does drive your temperature up slightly, and we see this a lot. So that's one thing that a woman can do naturally to just try to time ovulation. The other thing that she can do is kind of monitor her cervical mucus, okay? So cervical mucus increases because as the follicle develops, okay, during the menstrual cycle, the follicle gets bigger and bigger and bigger. Inside the follicle, something called a granulosa cell. The granulosa cell produces estrogen. So estrogen is a hormone that rises and peaks at the time of ovulation. So about 3 days before you actually ovulate, you're going to see usually a kind of a clear mucus, and that's a mucus that's very, very friendly to sperm. It's slippery, it's clear, and that actually, when you have intercourse, when you see that clear mucus, is going to be your best chance of conception. Now, what if you don't have that clear mucus? What if just naturally your body doesn't produce it? What type of lubricants might you be able to use? Well, water-based lubricants like KY are not good. Natural things like saliva, not good. They kill sperm. Olive oil, not good, okay? So what we're looking for is something called a hydroxyethyl cellulose-based lubricant, okay? And that is a lubricant like Pre-Seed, okay? Now, if you don't feel like running out to the pharmacy and you feel that this might be around ovulation and you want to try some household items that you may have to improve lubrication while you're having intercourse, mineral oil and canola oil are, again, very sperm friendly. And then something else that actually one of my patients recently used and did conceive is actually egg white. This may sound a little weird, but egg white and cervical mucus, again, have very similar consistency, and it can be used if you feel that you're ovulating and you're not producing enough mucus. So that's just a little bit on timing for the female, when you could be fertile, before ovulation. After ovulation has occurred, about 24 hours, your fertility window is over. Do you have anything to add to that, Dr. Dura?
Well, you know, it's interesting because I like charting for PCOS as well. So we have patients that are not sure if they're ovulating at all. And I think it's a really cheap, you know, easy way to figure out, at least if you have a pattern of some sort of change throughout the month. So if you can't get to your doctor's office, or you're looking for some way to measure, a lot of times the LH strips are not very accurate with PCOS. So I do think that that's really helpful. And I think also when you mentioned the lubricants, that's interesting because what do you think about coconut oil? Because that's something that
honestly, I've never read a study on coconut oil. There was a study done on natural fertility. It was published in Fertility Sterility a couple years ago. And again, they did not mention coconut oil. They did mention mineral oil, and the canola oil had been studied. But coconut oil hasn't been studied, so I'm really not sure about it. But
definitely.
But the
I just wondered
if people always find that one an interesting one.
I've heard it's interesting, and Pre-Seed is always a good one.
Right. Again, that one over the counter product.
Yeah.
If you're not going right to the kitchen.
Yes, and getting something on Amazon right now, by the way, is really hard. I don't know if anyone's tried to order anything on Amazon lately, but it's a long wait to get anything. So it's good to have these remedies that you can easily find in your kitchen, which is nice. And you know, right now everyone is practicing social distancing, so looking for different things to do. And I know that you've experienced this too, but we've had quite a number of pregnancies this past week and a half or 2 weeks. And with that also comes, you know, actually morning sickness, nausea. So as acupuncturists, we treat this very, very early on. Around the moment someone has a positive pregnancy test, we're actually doing points that are preventative for nausea. And so we start at 4 weeks, which I know sounds a little early, but we're doing these points anyway. There's a point on your wrist. You can actually look at the crease in your wrist if you fold your wrist, and then you go 2 finger widths down, and it's right in the center, and that's called pericardium 6. And that point is actually used for nausea, even for chemotherapy. So it's a really strong nausea point. We try to tell our patients to press on those points. And unfortunately, we've noticed, because we're not in the office right now, we've had a lot of morning sickness. And this doesn't usually happen so strongly when we're doing acupuncture because we're treating so much earlier. So with those patients, we have been, because we're not in the office, we've been recommending some strategies to do at home. So if you are newly pregnant, you might be wondering, okay, what do I do? What do I take? You can do B6 as well if you have B6 at home, and also ginger tea, which is also helpful. And, that's something that is usually very safe to do. There is also something called C-bands, which are used for motion sickness, but also very good for nausea as well. And that little it comes like a little elastic bracelet that actually stimulates that pericardium 6 point right there. So you can just wear those throughout the day. We also have been asking patients to use ear seeds, which are little pressure points that go on certain points in the ear. And those are also helpful for fertility as well. We've used some for that. So basically just ways we can help at home with this sort of treatment that can also be helpful. So have you noticed that you've had some good news lately from your patients, like that have been stuck at home for several weeks, or what have you seen?
We actually have, we have a lot of early pregnancies. Usually I found that the nausea doesn't hit again until they're probably about 7 weeks. But everything that you've mentioned are excellent tips, and that's what we recommend, for our patients as well. I just see a question here. It says, what can you do to prepare yourself for an IUI? Well, I mean, again, if you're preparing yourself for a fertility treatment cycle, I mean, at IUI, everything is about timing. So we want to make sure that when we're doing the insemination, that we are hitting the time just before the egg is released and then just after the egg is released. So having the appropriate timing is really going to be the best thing. And then what you can also do, if you feel that maybe the monitoring that you're doing for the IUI, maybe it's not quite accurate and you start to feel a lot of clear cervical mucus coming out and you're not supposed to be in the office for another 2 or 3 days, you may want to go in early and just check to see whether you're ovulating early. Most patients, we expect them to ovulate around day 12 to day 13 of their cycle, but there are some women out there that may ovulate earlier in day 8 or 9, and sometimes the mucus can key you in to maybe that's you. Sometimes patients will come in and we're trying to time their IUIs and their follicles already popped and we've kind of missed the window. So one of the things, again, you could do to try to prepare yourself would be just try to make sure that we get accurate timing on exactly when to place the sperm.
And so would BBT charting help as well if somebody is preparing?
The problem with BBT charting and insemination is that you really don't know, because once your temperature drops and then it spikes up, you've already ovulated, because the change in temperature, once it goes above 98.6 or 99, the deal's done. The egg's already missed your fertilization window. So basal body temperature charting is wonderful to look at retrospectively over a series of months to see whether a patient may be ovulatory. If their charts are biphasic, means low and then high, then yes, they are probably ovulatory. If in PCOS patients, it's always kind of spiky and kind of flat, then usually that's going to indicate that ovulation is not really occurring real well. So that's BBTs are great. Once we come to the fertility office, we are monitoring you a lot closer. But again, these are tips that you want to monitor your cycles. Right now, we're trying to prepare patients. I mean, you can't, since you can't get into the office, we're stuck at home. These are all sorts of tips that I have, and we have to share with you what you can do just in preparation. So if it works, wonderful. We'll see the baby in December. If it doesn't, we'll see you in our office in a couple of months, in order to help you out. So the other thing I just wanted to mention is just that was for the woman. The other thing I want to mention is from the guy side. So there's some misperception, okay, about gentlemen and ejaculation. So should a gentleman ejaculate every day? Is that going to decrease his fertility? And actually, frequent ejaculations do not decrease male fertility in a fertile male. There are some instances where it could be a problem if the gentleman has, fertility issues, but in a fertile male, ejaculations every day will not decrease his fertility at all. The other thing is that long abstinent intervals. So if a gentleman waits more than 10 days without ejaculating, then semen parameters will deteriorate. This is true. So we recommend that a gentleman doesn't abstain from ejaculation for more than 3 days, because sperm will only live for 72 to 90 days. The best pregnancy rate is, again, in a fertile male to have intercourse at least every day. This yields a 37% success rate as far as natural fertility is concerned. Alternative days will yield a 33% success rate, and once weekly yields only about a 15%. And this is with natural fertility, of course, success rate. They say, and this is why a lot of these just OBGYNs will say have intercourse every other day and you should be covered as long as the male is healthy. Your likelihood of pregnancy is the best when you have intercourse, again, just before ovulation. One thing that Dr. Duro and I spoke about just before this started was, again, what can, if you are affected, if you do get sick from the coronavirus, is this going to affect your fertility? So in gentlemen, we just want to let you know that if a gentleman gets a fever greater than 101, okay, this will lower his sperm count significantly in the 2 to 3 months after he had that illness. We see this in the flu all the time. We actually see this when gentlemen use hot tubs. So a gentleman can go out, relax in the hot tub for 15 minutes after work. He checks his sperm a week later, and we wonder why his sperm count is low and his sperm are slow. It's just because this could be just an effect of that excessive heat. So if any of you, it's not as much the woman, it doesn't affect them, but it does affect the gentleman. So if your partner has had a fever and has been sick, probably once he is better, you probably should get his sperm checked and just see where he stands, so at least you'll know where you are in the fertility ball game, for the next couple of months.
It's good to know, because there's some information.
I just want to answer a question since I saw it on the feed here. Does weight play a huge role? So it depends. Again, ideal body weight is best. Okay, as far as fertility is concerned, again, because women who are normal body weight have a more normal ovulation. Now, there are women who are over their ideal body weight and still do ovulate naturally, but we do have patients, and I know Dr. Duro sees a lot of them, that have polycystic ovaries, and they're over their ideal body weight. And what happens in women who are over their ideal body weight is that excessive fat causes excessive estrogen to be secreted. Your ovary, as I said earlier, makes estrogen, okay? So if your brain thinks that there's plenty of estrogen around that's coming from the excessive fat that a woman might have, what naturally happens is it suppresses ovulatory function, okay? Which is why some women have kind of a threshold. Over a certain weight, their periods space out and they even stop. And under a certain weight, they have more regular menstrual cycles. And it's because of the fat content in their body. And then for men, there's a similar effect. So for gentlemen who carry excessive weight, okay, estrogen is also leached into their kind of just system from the fat. And again, men, there should be testosterone dominant, not estrogen dominant. And that estrogen will also suppress testicular function. So I just wanted to answer your question. Hope that answered it.
Okay, and how can we think about improving egg quality if, let's say, somebody is waiting to do a cycle, or they have, I know that we have our own favorite supplements and things that are helpful, but what are your favorite ways to improve egg quality? Because we definitely get that question a lot with our practice. So I'd like to know your thoughts on that.
Well, again, we have to remember, okay, and this is with sperm, as I mentioned before, that 72 to 90 days, okay, it takes 72 to 90 days to make a sperm. Very similar for eggs. So in the 3 months prior to doing, any type of, say, fertility treatment, now this isn't, naturally it's nice too, but to try to do fertility treatment, what we try to do is optimize body mass, okay, which is key. So if your body fat, now you may not be fat, but you may have too much body fat. And if you have excessive body fat, as I said, it produces more estrogen, which suppresses ovarian function. So to try to optimize body fat, to take a look at where you stand as far as body fat, and then maybe try to reduce that by 5%, can make even fertility pills, fertility injections, in vitro treatment cycles work so much better, okay? So focusing in initially on your body and diet. Diet is extremely important, okay? And there's been lots of diets out there, but basically diets, with whole grains, with lots of vegetables, minimizing fruit, some protein and some fat seem to be the best diets. I like diets to advise my patients. I don't like specific diets. There's so many out there. There's paleo, there's Mediterranean, there's keto. There's so many. I mean, I like to advise patients to find a doable diet. And so what I think a doable diet really consists of is when you look at a pie, okay, we want half of your pie to contain vegetables, okay? Because vegetables can be your carbohydrates, but anything that is, orange and yellow and green and any color vegetable that you can have is going to be something that's extremely, extremely healthy for you, okay? And then we have to put about a quarter of that pie into fat, okay? And the fats we're looking at avocado, we're looking at olive oil, we're looking at healthy foods like that, and nuts, okay? We can put them in your fat column, okay? Let's not put butter in your fat column, okay? Then we want to look at proteins, okay? So we want to have at least a quarter of the pie, okay, being proteins. Now, proteins, they can be meat-based products if you're a meat eater. If not, we want to kind of avoid soy and tofu because also it can have phytoestrogens in it. But egg white is an excellent source of protein and beans and legumes and things like that. And then obviously you can add in the carbohydrates and other things like your carbohydrates. You want to minimize those. You want to put a little bit, just a little quarter of something with the carbohydrate, kind of like if you're going to do a bread, you want to try to stick with whole grains. However, with the whole grains, if you didn't make it yourself, okay, so when you see the products with the whole grains out there, is you'll see a product with whole grains, and if you look at actually a box of Lucky Charms says it's whole grain, okay, but do people think of whole grain like that's not kind of a healthy carbohydrate? Is a box of Lucky Charms. So the whole grains you want to think of, if you make it yourself, quinoa, wild rice. You want to try to avoid simple sugars, simple carbohydrates. So avoid the pastas, avoid really breads, even if they're whole grain breads and you didn't make it. Avoid white rice, avoid potatoes. All of things are kind of the kiss of death to kind of a fertility diet. So again, a plate filled with vegetables, some proteins, small amount of carbohydrates in the diet and some fats. This is what I would do as far as preparation for kind of a fertility based diet. Again, and then naturally, even if you're a little heavier, you have some excess body fat, your body composition is going to change. But there's simple stuff. I mean, that you can just do. I mean, just basically just diet. We're not even talking supplements. We're not talking about anything like that. But this is just kind of getting into healthy eating patterns. Something simple to think about. If it didn't come from the farm, field, or the ocean, don't eat it. Processed foods are really the kiss of death to, again, your body's health as well as your body's health regarding fertility.
Definitely. And I know that they did some studies in Greece on couples, which I thought was really interesting when they studied what they were eating during their IVF cycle. And the ones that were eating closer to the Mediterranean diet had higher pregnancy rates and healthier birth rates. But it also incorporated what the guy was eating. So I think that is really important too, to get them on board and kind of help, because there's no such thing as too much healthy sperm, I think. It's just we want them to actually be healthy too, so.
Yeah, I've got a question on here. So what exercise for losing body weight? So you don't actually want to lose body weight, okay? You want to lose body fat, okay? And this is where using a scale that actually measures body fat comes into play. So you could weigh 150 pounds, okay, and be 40% body fat. But you could also weigh 150 pounds and be 35% body fat. So therefore, what you have to do when you're trying to exercise, you have to kind of build muscle, because in general, exercise is not, you're not going to lose weight exercising. Okay, the diet is the most important thing as far as losing weight. What I like exercise for as a fertility specialist is stress management. Okay, one thing about exercise, however, is that high intensity exercise has been shown to have a negative detriment on fertility. So you want to stay with aerobic exercise, not anaerobic exercise. So again, 30 minutes of cardio, wonderful, but don't push it into the, if you do Orange Theory, don't push it into the, the orange and the red zones a lot. Stay in the green, stick with that. But again, exercise involving building muscle mass is going to increase muscle and decrease fat naturally. Okay, and so you need to know where you stand on a body fat scale. And again, we have very expensive, nice scales in all of our office. We try to do a metabolic analysis in all of our patients that come in to just kind of see where they are. And then we try to give people small goals. But again, if you can knock that body fat down from 40% to 35% or 35% to 30%, that is going to be extremely helpful as far as any type of response to medication, and extremely helpful for egg quality and outcome.
No, definitely. And some of those newer scales will also have a function at home. Maybe you already have one, that you can look at, that might not be nearly as accurate as an in-office assessment, but at least it'll give you an idea of where you are as far as body weight, and not just looking at the pound side, which I think is really good advice. So as far as, when we talk about egg quality, I think it's important to mention a few key supplements that I know that we try to stress that our patients have, along with eating a healthy diet and all of that. Definitely omega-3, I think, is really important. They're finding so much for not only, egg, but sperm quality, and also vitamin D. So a lot of times we see patients that are vitamin D deficient, and that's definitely could interfere with a regular cycle as well. So if you look at your vitamin D levels, optimally, we like to see it in the 40 to 60 range usually. Is that what you guys look for also with your patients as well?
Definitely. I like 40 to 50, somewhere in that range. Yeah, exactly.
Yeah, and I think too, even with, all of the things that we try to emphasize, like those are the building blocks, a good prenatal with some methylated folate, and also a good, omega-3 along with vitamin D. So
right. Well, yeah. Just let me mention a little bit about. I've got a thing about folic acid as well. So folic acid is a supplement that essentially back in the 1970s, we were told that if women took folic acid, then this would eliminate birth defects 100%. Okay, and so. It had essentially, however, there is a mutation called MTHFR, and MTHFR is a mutation that unfortunately most insurance companies don't pay for, so I just have to assume that everybody has it. If you have certain mutations in MTHFR, the folic acid that you are ingesting, whether it's in the form of an over-the-counter pill, whether it's in the form of broccoli or spinach, it has to be broken down from folate into folic acid, and then the folic acid goes to alpha methylfolate, and then alpha methylfolate goes to quatrefolate. Okay, this enzyme methyl tetrahydrofolate reductase is what's responsible for taking the folic acid from the folate down to the quatrefolate. Quatrefolate is going to be your absorbable form of folic acid. So unless your prenatal has alpha methylfolate, which needs only to be broken down once, or it has quatrefolate, which gets immediately absorbed, okay, you might not be absorbing the folic acid that you think you're taking. So that's the problem. Without knowing you have the enzyme or you don't have the enzyme, it's just best to take a prenatal that's more absorbable. So that is one of my pet peeves, because again, if you can't check it, and again, it's not something that is normally checked for in a preconception panel or a prenatal panel. You want to also make sure that for the 2 to 3 months before you conceive, your body has adequate iron stores and adequate folic acid stores, because this folic acid is going to be key to preventing those birth defects. I've had 3 patients early in my career that were all on prenatal vitamins, and unfortunately all these ladies had birth defects that were associated with the neural tube. Retrospectively, when we checked them, when they tried to get pregnant again, they all had the MTHFR mutation. So after these 3 cases of mine, really back in 2000, 2002, I've become kind of a prenatal vitamin Nazi as far as making sure that patients are ingesting enough. The other thing you have to remember, and just because since we were talking about body weight, is that if your body weight is over 35, your BMI, okay, it is also recommended that you take extra folic acid. So instead of the normal folic acid recommendations, which are just approximately 1 milligram of folic acid. If your BMI is over 35, you're at 2 to 3 times the increased risk for neural tube defects than women with a BMI under 35. And therefore, you should be on extra folic acid, which should be considered to be a quadrifolate, a prenatal with that more absorbable folic acid in it, and an extra 3 milligrams of folic acid. So actually 4 milligrams of folic acid is recommended for anybody with a body weight over 35. Sometimes this gets missed, but this is something that really important, because if you're going to, especially doing fertility treatment, go to the time and effort to do treatment to have a baby, you certainly want your baby to be healthy. I mean, all of our patients, we do have them on a prenatal with more absorbable folic acid, but we're talking about people at home, people just, just having fun, and having babies. But this is something that is super important. Just get that body prepared. Make sure you're taking an adequate amount of folic acid, because we certainly want that baby to be healthy.
That's really important. And would that be a prescription folate that you're recommending?
You can just take them over the counter. I mean, you can just basically take, they sell them in 800s. You can just take 5 of them. If you're not using a prescription prenatal. So, 800, that's the highest dose they sell over the counter, but you would take 5 of those a day. Just if you're at risk. And again, patients who are, sometimes a little heavier, they may be getting pregnant, they may be ovulating. Again, they may not come to my office. But this is something that, by the time they hit the OB, the neural tubes formed between 11 and 12 weeks, and sometimes you may not see your doctor. And if you're deficient, and your poor child, has spina bifida or something, it's really sad, because these are such preventable things. But without that knowledge, you didn't know that you should have been taking it.
And I would say some medications could deplete folate as well. I mean, so they have to be careful, like metformin or your B vitamins too. So
right. You need to also be taking a B complex, and you have to add in B6 and B12, or your body can't absorb that much folic acid. So, but again, you don't know whether you're deficient in this MTHFR enzyme. You just have to assume you may be. Some people are, some people aren't. The incidence runs about 40 to 50% that some people have some sort of deficiency. So it is kind of common.
Okay. And would you recommend that someone check with their OB if they, just to find out, even if the insurance doesn't cover that, or you just kind of assume it?
Some people do. I mean, I have some patients who have proactively, requested the test. It's also, I have one patient who, she definitely feels that her son's learning kind of autism spectrum disorder is potentially linked to that enzyme deficiency. I do believe. I mean, I think there's a wide variety of things that these very simple treatments can help, and they're sometimes missed because they're not considered.
Okay. There is a question about Lupron for endometriosis.
Also, glass. Drink out of glass.
Yes.
That brings up plastics. Plastics are bad. So we do find also, again, plastic water bottles can be very bad for fertility.
Big tank bottle here.
I just thought of it when I went through my glass cardiac. Yeah. But plastics, we also do find that to try and rid your body of use of plastics, microwaving in plastics, drinking out of plastic water bottles for a minimum of 3 months before you do a fertility treatment cycle. It can only be beneficial to future fertility. What happens is the plastics, you leach these chemicals into the water when the plastic gets combined with heat. And when you go and drink the water, you're basically drinking toxins. And it will take several months to get these toxins kind of out of your body by not ingesting them. And there's definitely been animal data that has supported poor embryo development and fragmentation risks, as well as fertility in patients who are constantly exposed to plastics. We recently had a spontaneous pregnancy in a woman who worked in a factory that made fabrics that was flame retardant. And she had very, very terrible hormone levels. And basically I told her that she needed a new job. Anyway, she actually 6 months ago quit her job, and she was spontaneously pregnant. We did her OB ultrasound today, but this woman is 40 years old with an FSH that was ridiculously high, and her baby looks great today.
Wow.
But so toxins are something that you really should look at around your life, especially in preparation to do any type of fertility cycle or just even trying to get pregnant naturally.
And especially now, I just want to mention one
Yeah.
thing about toxins. We have a lot of cleaners that everyone's using right now with Clorox, which
Oh,
usually,
yeah.
you know, I mean,
Petroleum-based toxins also bad for fertility.
yeah,
But
so, right, we're all using them. They're spraying them everywhere. It's all around. So hopefully after this pandemic, we can get back to some natural cleaners or, you know, look out for that as well, especially with endometriosis and different autoimmune issues.
all right, I see a question up here that I'm going to answer. So it's, what do you think about Lupron for endometriosis? Well, I think about Lupron. I mean, Lupron is a very, very old drug. We've been using it for a long, long time. And we're using Lupron out of lack of anything else to do. So there's a standard pathway when we're talking about endometriosis. We have to look at endometriosis as treating it for pain, and we have to look at endometriosis as treating it for fertility. So if we're treating it for pain, you know, nonsteroidals are going to be your first line therapy, and birth control pills are going to be your second line therapy. Lupron is, you know, something that we use as an adjuvant to possibly surgery, and sometimes we use it empirically because we don't want to go to surgery. There's goods and bads for it, but it depends on what other treatments that you've tried, whether we consider recommending Lupron. And whether you're trying to get pregnant. I've had some pregnancy successes after giving Lupron for several months for endometriosis, and people have gotten pregnant spontaneously. And then the other drug that I was just about to mention was the Orlisa. But the Orlisa, the results with the Orlisa are excellent. Problems I've had with prescribing it has been insurance coverage. We have not been able to get patients who are candidates for it covered. But if someone is a birth control pill failure or Orlisa failure, then, you know, Lupron is one of the ways to go. Other alternatives for that is to use Depo-Provera shots monthly. And then as a last resort, patients could use a combination with letrozole and norethindrone acetate, or patients could also use, and I have a handful of patients on a very, very, very old drug called Danazol. But it all depends on your specific situation, whether it's related to fertility or whether it's related to pain, or whether we're trying to preserve fertility, whether we've had surgery, or whether you haven't had surgery. Again, there's a whole bunch of questions I would have for you. Okay, all right, yeah, good point. So yes, the treatment for Orlisa at 6 months is the recommended dose. You can go beyond that dose. It is off-label. I would prefer to keep somebody on Orlisa, okay, and before I put them on Lupron. I would keep them on Orlisa. I would check a DEXA scan, because that is the fear is that if you do not have enough hormone in your body, that potentially you could not unless you, sorry, just keep asking these questions. I don't know whether everybody else can see them, but so Orlisa, again, the big thing is bone loss and the indication of only 6 months. So you could stay on Orlisa longer. It does have a tendency to exacerbate patients with depression or any type of suicidal ideation. It certainly can make that worse. But if that's not an issue for a patient, I would probably keep them on longer, make sure that they're doing weight-bearing exercise, calcium, vitamin D, and the data, I was just at the conference, and there is data coming out about using add-back with the Orlisa to prevent bone loss. And that is the concern. That's why you wouldn't use it longer than 6 months is bone loss. But I think with adequate calcium intake, vitamin D intake, and weight-bearing exercise, you could stay on Orlisa longer. And I would personally prefer to use that over going on Lupron.
And for those that are not familiar with that drug, can you tell us a little bit about that medication?
Right, yeah, so Orlisa, it's a new drug that came out, and it suppresses the pulses that the pituitary gland sends out to the ovary, and that essentially suppresses the food that goes to endometriosis, which is a disease where the endometrial tissue gets implanted outside of the uterus, associated highly with fertility. infertility, I meant, and associated with a lot of pelvic pain. Yes, and again, the add back is agestin, and that does protect bones.
Okay, and I'm glad that, thank you for bringing up endometriosis. Last month was Endometriosis Awareness Month. We were scheduled to talk a little bit more about endometriosis, but coronavirus took over a little bit. But there are some really good suggestions for, coping with some of endometrial pain naturally as well that we use. And, they can be used in conjunction with medication or unmedicated. And I know for one thing, whatever treatment you're doing, if it's not working, make sure to go ahead and get another evaluation. If you're still having pain and a lot of clotting and dark discharge, that's something that needs to be addressed. Don't suffer in silence. There's definitely a treatment that will work for you. It's just finding out what that is. And I know many years ago, Dr. Wood and I had a mutual patient who wasn't getting better with natural treatment, and I referred her back for an ultrasound, and you actually did a biopsy, and she had endometrial cancer. So, as a caution for women, I think it's important to not suffer needlessly. And also, this patient was trying to get pregnant, so I think it's a rare thing, but it can happen in reproductive age women as well. So we need to make sure to make people aware of that and make women aware. So as far as our natural treatment goes, we look at omega-3. We have herbs that actually are helpful for relieving pain, and they're also good for circulation as well. So we kind of look at the period like a report card, where it should be more bright red flow instead of dark discharge, and that kind of, we call the brown sludge, is usually a sign of that poor circulation. So that's important. And if that's getting more bright, less clotty, less pain, that's always a good sign for us. And with mild endometriosis to moderate, we can help naturally as well with acupuncture too. So,
well, again,
Dr. Wood,
just to lean back to this, the one question on here. But again, Orlisa is a wonderful pill. I would probably continue it. I would get a DEXA scan, check your bones. If you're on agestin, add back. I think that sounds excellent. And as long as your bone health is good, I personally would continue the Orlisa.
So great. So as far as birth control goes, if somebody is on birth control to kind of waiting out their cycle, what would you recommend that they kind of usually continue on birth control for several months, or have you seen any negative effects of that with the ovaries or endometrium in any way?
Well, we use birth control very, very liberally, and birth control really, it's the first line treatment again for endometriosis. So it suppresses it, and it's cheap, easy, and very, very easy to use. That's what we're referring to?
Right. Well, basically, let's say somebody is on hold. We've had some patients who are on hold for their treatment. They're either going to prepare for IVF or they're waiting for things to kind of normalize again. So they're basically just on hold using birth control. And, some patients who are prone to cysts, that seems to help, and some patients it seems to do the reverse with, So how long would you recommend somebody stay on birth control when they're preparing, especially if they have perhaps an egg quality issue or advanced maternal age or anything like that?
We try to we try to minimize it in preparation for the treatment. If you're older, again, we use birth control for timing purposes, basically.
Mm-hmm. So yeah, not forever and ever.
Yeah, okay. not forever and ever. But yeah, I mean, when I just want to get back to this young lady's question, with all of these treatments, again, I've used Lupron, Lupron is only recommended for 6 months as well. And again, an off-label use would be to continue it for longer than that. And I think, again, that the reason they say 6 months is because that's what the data says. There's no data beyond that. And again, we are worried about Lupron past 6 months, bone health. We also worried about Orlisa beyond 6 months, bone health. And that's the primary concern. So I think with vigilant monitoring of bone health with DEXA scans, you could stay on either one of these drugs, longer in order to control disease. And again, you're trying to control the disease, okay, of the endometriosis with any of these drugs, okay, in preservation for fertility. Because a lot of times once you failed all these drugs, or we say, you know what, your bones are, we're not saving your bones here, you need your estrogen add back, or you need your progestin add back to keep your bones healthy. Do you want to get pregnant? Because many times pregnancy can be a great cure for endometriosis. So we're trying to temporize until we can get you pregnant. And a lot of times we're trying to temporize in ladies with pain, and they're not ready to get pregnant. So that's where you have to kind of play with these drugs. So I would talk to your physician about extending it 3 months, see how you feel, 6 months, see how you feel. And the reason we can't really recommend this, especially if you're feeling good, is because the data is not there. But the main concerns are your bones.
So it's a great point to bring up. And I think so many patients have questions about the right kind of treatment for endometriosis. And I guess the answer is it's individualized as well, according to the patient too. So, and what your goals are, right? And your age and that sort of thing too. So definitely these are really great questions. I hope that we can kind of summarize for you. If anything, we can try to stress that the thing you can control right now is trying to take control of your stress level. We can't control the news. We can't control what's happening around us right now, but we can control how our body responds to things. So if you're feeling that your stress level is going through the roof, that can definitely affect everything else in your body, emotionally, hormonally, and all of that. So we try to tell our patients to do box breathing if you've ever felt anxious and that sort of thing. It's basically just taking 4 deep breaths for 4 seconds and then blowing it out for 4 seconds. So you basically can do this anytime you feel nervous or anxious, tension, that sort of thing, and know that things will pass, things will get better. Life will go on, and we're going to definitely, try to make the most of this time. So would you have any other thing to add, Dr. Wood, as far as anything that's come out this week with fertility or pregnancy and the COVID-19 pandemic?
Again, I like to try and figure out how we can make lemonade out of lemons, okay? And this is the perfect opportunity, I think, for people to try and get their bodies healthy in preparation for a treatment that they may have been ready to start. You can always get healthier, okay? Or try to, just look to the future. So look, you know you're going to need IVF, whether it's for this reason or that reason. You haven't really started your treatment. But now this gives you the opportunity to really blow it out of the park when you start. Many times patients will come in, they know they need IVF, they sit in front of you, when can I start, doc? And I said, well, we don't want to start right now. Let's try and, let's make you a little bit healthier before we start. Let's make your husband a little bit healthier. Let's try to make his sperm look a little nicer. Let's try to make your eggs a little healthier. And lots of people don't want to do that. We don't want to, they're ready. They decided we got there, we're going to start our IVF cycle. And to tell them they have to wait 2 months or 2.5 months to try and nourish themselves is not something that a lot of patients like to hear. We try and insist on it. I mean, all our physicians really try to insist that, that lifestyle is key to success. This is an opportunity to, again, say, look, we're trying to get pregnant. It's not working. Let's try and, we may need treatment, whether it's just little treatment or big treatment. But this is the time where you can, again, try to optimize your body mass, to try to optimize your nutrition, optimize your health. And in that respect, this is great. I mean, we're kind of in a holding pattern. So moving forward, again, this is our lemonade, to just make our treatments that are going to happen, hopefully starting May or June or July, work.
Right.
And then I just see a quick question here. How long should we wait after pregnancy to transfer another embryo? Again, as far as that's concerned, after you delivered, it's 6 months after vaginal delivery, 9 months after C-section. I wouldn't even consider pregnancy. OBGYN, American College of OBGYN recommends a year to 18 months. And a lot of it's just to have your body to recover. But the biggest thing is that you can't be breastfeeding. So you can't start any type of treatment for an embryo transfer while you're breastfeeding. So you do have to wean after that. But we do not recommend getting pregnant any earlier than a 6 months of vaginal delivery or 9 months after a cesarean, but preferably longer than that, especially if the embryo is frozen. It can wait. But again, it's just trying for your anemia of pregnancy to recover and for your body to be as healthy as possible.
Great. Well, this has been so much fun, everyone. I'm really grateful for Dr. Wood for coming on and sharing your wisdom with us. And we're going to be back next week. So if you didn't get your question answered, please, you can DM me. And also, if you'd like some recommendations as far as some of the dietary things that we talked about, we do have, our office has a free 30-day COVID-19 preparation plan that basically has, meal prep, some recipes that are really yummy, some smoothies, and also some mind-body exercises, some yoga, and a little meditations you can do from home. So you can feel free to send your email to me. You can DM me for that. And then if you'd like to get in touch with either one of us, you can go to ivfmd.com or Florida Complete Wellness. And both of us are offering telehealth services or telemedicine as well during this time. And again, thank you guys, everybody, for joining us. We'll be back next week at the same time, same channel to answer your questions. So thanks so much, everyone.
Thank you so much, Dr. Jura, for setting this up.
Thank you.
This worked really great.
Great.
This is really exciting and great questions.
Great. I had a lot of fun. And be safe, everyone. Take care.
All right. Yes, be safe and healthy.
Bye.